Good morning, everyone. Just a quick announcement. Dr. Greenberg will be here in 1 or 2 minutes, so we're starting in just a few, but we got plenty of time.
What?
All right, I think most people are here and you've all had a chance to get some lunch. Welcome to the Surgical Practice Luncheon, and thank you very much for attending our session. I am Stefan Leicht with the Nova Health System in Northern Virginia, and together with Dr. Trey Bradley from Vanderbilt, sitting over here, will moderate the session today. And our invited speaker is Dr. Caprice Greenberg from UNC Chapel Hill. Dr. Greenberg is the chair and Colin G. Thomas Jr. Distinguished Professor of Surgery at UNC Chapel Hill. She earned her medical degree from the University of Chicago and her MPH from the Harvard School of Public Health. Dr. Greenberg completed her general surgery training at the Brigham and Women's Hospital in Boston and her surgical oncology fellowship at the Dana-Farber Partners Cancer Center in Boston. Dr. Greenberg is a world-renowned health services researcher, and she is a leader in the study of care delivery in operating rooms and innovative approaches to collaborative learning and surgical coaching. We are very happy to have Dr. Greenberg at the luncheon today to talk about surgical coaching for performance improvement. We will first have Dr. Greenberg's presentation, and then we have 30 minutes or plus for questions and discussions. And so any questions you may have, please write them down or remember them, and we'll have a good discussion after the presentation. Thank you again.
Great. Thank you so much for the opportunity to be here today. I do have one disclosure. I serve as president of the Academy for Surgical Coaching. This is a nonprofit organization, and I'm not paid for my time, but the Academy has received funding from Johnson & Johnson, Intuitive, and Hologic. So my goal today is to talk to you about the concept of surgical coaching, and this is the outline for what I want to cover. I want to talk about what gaps we're trying to fill, what video-based surgical coaching is, what the evidence is, and how we can operationalize it. And I'd like to suggest that there's two things that we spoke about this morning that might help as you put this in context for our discussion afterwards. The first is, how might regional organizations like this organization be involved in concepts like surgical coaching or increasing ways that we approach collaborative learning? And the second is how this might help us to address some of the issues that we heard about in our presidential address related to the house of surgery. Some of the discouragement people are feeling, some of the isolation, and how might these concepts work to bring us closer together? So I'd like to just set that background, and then hopefully with my comments, we can have a robust discussion about how we can move this forward within the house of surgery. So what gap are we trying to fill? Many of us like to think that when things go wrong in the OR, it's because somebody's doing something they shouldn't do, or there's something that leads us to be protected from that happening to us. And if we actually look at the data, when there's a technical error in the operating room, it is most often during a routine operation. So if you look at the first blue bar, let's see if I don't think I have a pointer here. It is routine operations as opposed to index operations. So it's lap choles as opposed to Whipples. And it's most often experienced attendings operating within their specialty. So again, that's the blue component of the first, which is routine operations. And even when things happen in an index operation, it's most often people who are doing what they do every day, what they're trained to do, and what they're experienced in. Now, we also know from this landmark paper from 2013 that there's variation in surgeon skill. So this was a study that came out of Michigan where the bariatric surgeons there sent out their videos to each other, and in a blinded way, they rated each other on a scale from 1 to 5. And that's on the y-axis, you can see. And on the x-axis is just the individual surgeons. Then as you can see, there's pretty wide variation in how attending bariatric surgeons rated each other in their ability to perform a bariatric operation. Now, the reason that this paper was particularly interesting was because they had robust risk-adjusted outcomes, and they were able to look at the relationship between how practicing surgeons rated each other on a technical scale in a blinded way with that surgeon's clinical outcomes. So if you look at the scatter plot on the left, you can see that the surgical skill rating, that 1 to 5, is on the x-axis. And the risk-adjusted complication rate is on the y-axis. So the surgeon with the lowest technical skill rating by their colleagues had a complication rate that was about 4 times the surgeon who had the highest technical skill rating in a blinded way. So again, this really is the first time that we were able to quantitatively show something that I think we all innately know, right? What we do in the operating room matters, and there is variability in our technical skill and how we're able to take care of our patients. Now, this held up when they looked at a bunch of other outcomes, which you can see on the right. And this study has been replicated in a number of different procedures. This is just one example. This is in colectomies, so colorectal cancer procedures. And the outcomes along the top row are related to technical skill, and the outcomes along the bottom row are related to non-technical skills. And you can see the surgical complications versus the medical complications. There's a correlation, again, with how surgeons rate each other in a blinded way using a technical skill instrument between how their patients do in terms of technical skill related outcomes, but not non-technical skill related or medical outcomes. This is from a similar group of patients where they looked at what happened in terms of long-term outcomes for patients after treated for colorectal cancer. And you can see that there's actually a pretty significant difference between highly skilled surgeons' patients and their long-term outcomes for patients at 5 years compared to those who had lower technical skills, probably due to the quality of the cancer operation. So again, not only does it influence how our patients do in the short term, but there's emerging evidence to suggest that our technical skills in the operating room influence how our patients do in the long term as well. And more of this data is becoming available about us, right? We know that this is on the web. We know that there are different reports and different ways that we can find out what our skill is or how our patients are doing. But the question is, does that then translate into improved outcomes? And these two studies that were published simultaneously in JAMA show that there actually was not a correlation between improvement over time for those who participated in NSQIP compared to those who did not participate in NSQIP. So just measuring outcomes is not enough, right? Outcome measurement does not equal practice improvement. And I would argue that for the last few decades, we've really spent the majority of our time figuring out how to measure what we're doing, right? We spend all of our time in that first bucket in performance assessment. But what we haven't done is figured out how to move through the rest of that PDSA cycle, right? How do we identify areas and set goals for improvement? How do we actually reflect on our practice and what we do and identify areas that we want to make changes? How do we then go and make those intentional adjustments to what we do and then go back to our performance assessment again and see how our practice has changed? There is no really structured way that we do this right now in surgery. And the problem is that we don't have a good way to get feedback. So this shows you what happens over time. And this has been well described by Anders Ericsson. It's called the proficiency plateau. So over time, right, we practice, we don't get feedback, we get comfortable in what we do, and we fall off of our improvement curve. We stop getting better, right? So the question is, how can we get back on that curve, figure out how we give each other feedback in a structured way, and continue to improve throughout the life of our careers? And the American Board of Medical Specialties has actually started to recognize this. So this was a report that was published in 2019, where they got together and talked about a vision for the future, what the future of continuing board certification would look like. And there's a couple of salient points that I really want to highlight here. So continuing certification must change to incorporate longitudinal and other innovative formative assessment strategies that support learning, identify knowledge and skills gaps, and help diplomats stay current. The ABMS boards must offer an alternative to the burdensome, highly secure point-in-time examination of knowledge that we currently use for continuing certification. A couple of other points. Continuing certification is unique from initial certification, right? The first time we get board certified, it's all about making sure that we're competent, that we should be doing what we're doing. But from that point on, we really need to move to formative evaluations. How do we, again, continue to figure out what we're doing well and where our areas are for improvement? And that needs to be grounded in adult learning principles. It needs to be individualized and goal-directed. My goals are going to be different than your goals. It needs to be frequent spaced learning with timely feedback, repeated for reinforcement, and it needs to be, again, based on a gap analysis. So what is the one thing that you're trying to improve right now? They also go on to talk about procedural skills. And I think, in surgery, this is something that we have to be really thinking a lot about. We haven't thought about procedural skills in a very long time. Again, if we think back to how board certification started, you used to have somebody come out and watch you operate to make sure that you should be board certified. And we moved away from that because logistically we weren't able to do it. And I would argue that, as you'll hear as we move along in this talk, video is coming to the operating room, and that's going to allow us the capacity to start looking at what people are doing in the operating room again. So we really have to take charge of this and figure out how we're going to use technical skills and procedural skills in board certification. And I would argue that, again, for people in practice, we really want to be using it in a formative way as opposed to a summative way. So coaching aligns with much of the vision for continuing certification. Throughout this document, I just highlighted a couple of different passages so you can see how often they use the word feedback. It's all about getting feedback to people who are in practice. Okay, so what is video-based coaching? If we think about coaching, right, all of the best athletes have coaches. So why is it that people in other specialties and other disciplines can work with coaches throughout their career to continue to get better, but we in surgery don't necessarily do that? Now, I'll argue that executive coaching has started to find its way into the House of Surgery. And I think that's helping us to understand that coaching is not about remediation. Coaching is about improvement, and it's about improvement for everybody. So coaching means unlocking a person's potential to maximize their own performance. It's helping them to learn rather than teaching them. It's about providing objective and constructive feedback to help someone else recognize what works and what can be improved, and inspiring them to maximize their potential. So you'll notice from these definitions, coaching is all about someone else. It's not about taking your knowledge and giving that to someone. It's about working with someone to pull out their knowledge, to be there in service to them and their own self-assessment and their own self-improvement. So coaching is based on adult learning theory. Again, you're going to hear me continually talk about these different concepts, but it has to be goal-driven. There has to be active participation on the part of the person being coached. They have to choose to participate in coaching. It needs to be tailored to the experience. The way somebody who's 1 year into practice is going to be coached is very different than the way somebody who's 20 years into practice is going to be coached. And it should be iterative and longitudinal. And again, it's based on this continuous improvement cycle. So setting a goal, asking good questions, looking at what you're doing in practice, identifying things that you want to change, holding each other accountable to actually make those changes, and then looking at how it impacts your performance. So when I talk about the concept of surgical coaching, I'm talking very specifically about coaching that's focused on improving clinical and operative performance, and therefore quality and patient safety. I'm not talking about leadership coaching, executive coaching, or wellness coaching. Those are all incredibly important, and the techniques that you use and the ways that you interact are very similar. But the topic or the target of what you're talking about is specific to the ways that we take care of patients. Now, many people, when I talk about coaching, say, well, this is just a sort of fancy new word for something we've been doing for a long time. And I would argue that it's actually quite different than mentoring and teaching, which are traditional educational paradigms. Now, all of these are about supporting the development of somebody that we're working with. But coaching is unique in that it uses open-ended questions, it enables self-discovery, it dispels false feelings and beliefs, and it's really focused on the future and building capacity. This is a nice summary that was published in Annals of Surgery, and the folks in Toronto, along with the folks at the American College of Surgeons, did a systematic review of coaching to try to, again, come up with what are some of these topics or these criteria that really define something as a coaching interaction. So it's about refining performance of an existing skill set. Again, I'll talk a little bit about how you can use coaching as an adjunct to acquiring new skills, but in general, coaching is to get better at something you already know how to do. It's meant to really be based on two-way communication and voluntary participation on the part of the person being coached. And the person who's being coached has to have some kind of training and really be structured around some kind of a coaching framework or a coaching model. This is one example of a coaching framework. We developed this in Wisconsin by studying coaching in education, athletics, and music, and really tried to identify what are the things that you want to be able to adjust for or control for. So you want to be able to have any surgeon participate regardless of where they're practicing or their own personal characteristics. You want to be able to address any kind of operative context. The blue along the outside are the things that you can adjust for, right? So how do you pick coaches that have the right knowledge and experience? How do you make sure that your coaches have the right interpersonal skills? And then the coaching context, where is this? Is this done at your institution? Is it done through an organization like this? Is it done nationally? And we've worked with coaching programs at all of those different levels. And then on the inside, again, at the bottom are those activities of coaching and the focus of coaching. So when I talk about the focus of coaching, we're really talking, again, as I mentioned, about surgical performance. And this is based on the work of Steve Ewell and Rona Flynn in Aberdeen, where they really define what are the different buckets that make up surgical performance. Now, like any framework, this is artificial. It's really hard to talk about your cognitive skills and not talk about your technical skills. But this bucket really helps us to frame a coaching conversation. So some people want to work on their technical skills. They want to get faster. They want to be more efficient in the operating room. Some people want to work on their decision-making or their judgment, knowing when to operate, know when not to operate. Other people want to work on their interpersonal skills. How can they better communicate with anesthesia? How can they be a better teacher? How can they better interact with their first assist? And then this last bucket actually wasn't a part of the original model and wasn't part of the model when we started doing this work, but we saw it come out iteratively in our conversations, and then it started to appear in the literature, and it's this concept of self-regulation. How do you recognize when you're starting to get stressed in the operating room if the case isn't going the way you want it to go? And then how do you regulate your response to that to make sure that your interpersonal skills remain constructive, to make sure that your technical skills remain where they need to be? So the competencies of coaching, what is it that we teach coaches to do? We teach them to be active listeners. That's the single most important thing. It's critical to developing trust, rapport, and the ability to develop powerful questions. The best thing you can do as a coach is to really listen to understand what the person that you're working with is trying to tell you. We teach people how to ask open-ended questions and to challenge in a non-competitive, non-threatening manner, and then to give effective feedback that's descriptive, specific, actionable, and non-judgmental. So I think video is a really important part of coaching. I do think sometimes people get really focused on video and the fact that we're not where we need to be in our ability to capture it, right? We can do it for lap, we can do it for robotic cases. It gets more challenging for open cases. As a breast surgeon, as an endocrine surgeon, it can be really hard when you're working in smaller spaces to be able to capture that video. But the video is just a tool for a conversation. And there are ways to have wonderful coaching interactions, even if you don't have video. The reason video can help, though, is because it allows you to view your own performance, whether it's the way that you're interacting with someone to see how you come across or to see what their reaction is to you, or whether it's looking at how you are doing technically when you're failing to progress during a case, something that sometimes you can't really recognize in the moment, but you can when you're looking at a video afterwards. It's been shown to be more successful in sustaining behavior change. It confers a time savings of 50 to 80%. It's important because it removes the concurrent responsibilities for the patient on the table and allows you really one of the only times to fully concentrate on just your own performance for 30 to 60 minutes. That is an incredibly valuable thing to do. And then it mitigates medical, legal, and credentialing complexities on the part of the coach. For the most part, almost everyone we've spoken to about this believes that we can develop these programs under peer review. So pulling all of this together, a peer coaching interaction takes place when you have a surgeon who identifies a goal related to either their technical skill, their cognitive skill, their interpersonal skill, or their self-regulation. And they work with a coach who helps them to set that goal, asks them good questions, gives them feedback, helps them to reflect on their practice, helps them to identify things that they want to change, and then holds them accountable for making those changes. Coaching really takes a mindset shift. When we go into the operating room as practicing surgeons, we're experts, right? Our patients expect that of us. Our colleagues expect that of us. We know the answers, and because we know the answers, we show little curiosity. We rely on habits, routines, and rules, and we feel competent, complete, and comfortable. And again, we have to feel that way to go in there and operate on another person. What coaching can do is to give us space to move into that learner mindset again, to wonder about answers, to show great openness, to challenge our assumptions and beliefs, and to continuously test our competence and see if we can push ourselves to be better or to do things differently. This also requires not only a mindset shift in ourselves, but really a culture shift for us in the house of surgery. And we did a study where we worked with the surgeons in Michigan, and I'm going to show you the quantitative results of that in a minute. But the qualitative results of this were that surgeons actually felt that starting to work with each other in a surgical coaching framework could actually help to challenge some of the issues that we have in surgical culture and help to move the needle. So when we first introduced this study, surgeons were concerned that participating in a coaching program might make them appear vulnerable. Despite their concerns about image, they were willing to participate, motivated by getting those outcomes and seeing that they were average or below average, or a desire for early career affirmation. Participating in the coaching program challenged their current social and peer expectations, and participants ultimately viewed coaching as a way to improve the culture of surgery and felt actually quite comfortable interacting with each other in this way once they tried it and got going. So what's the evidence? Is there any evidence that this actually works? So this was one of the first paper study. This was a study that we did in Wisconsin in conjunction with our state chapter of the ACS, the Wisconsin Surgical Society. We had 11 surgeons who worked with 8 peer coaches, and these were for in-person sessions using OR video. In this study, we found that surgeons chose specific coaching goals related to technical and non-technical skills. Both coaches and coachees participating in the study found that the coaching program was highly valuable. And to me, most importantly, surgeons reported making sustainable changes to their practice as a result. I remember when I presented these results back to the organization from which we drew the surgeons, and I had 3 different people stand up during the discussion session and say, I participated in this study and I made a change to my practice that I maintain to this day. To me, that's what this is all about, trying to figure out how we help each other get better. This was a study that was done around the same time at Harvard. And again, the surgeons reported high perceived impact on patient care through improved teamwork skills, communication skills, and situational awareness. They weren't able to show a quantitative change in either the measure of technical skill or non-technical skill. And one of the things that I've been super interested in is this idea of well-being and burnout, and whether or not coaching can help us to find ways to have people feel more fulfilled and more connected. And the surgeons who participated in this study really felt like this did have the opportunity to reduce stress and enhance peer support if we can do it in a way that it doesn't increase work overload. And that's the reason I think when we're away at places like this, we should find time to get together and do these coaching sessions where we're already taking time out and it's not adding to our workload. In terms of technical skill, this was a really small study, and it comes from the cleft palate repair work. And what they did was they identified 2 surgeons who had above average fistula rates following a cleft palate repair. So the 2 surgeons had a complication rate of about 6% pre-participation in a coaching study. And in the post period, they had no fistula. Again, small study, can't make any statistical references, assumptions about this, but I think that it shows that there is potential here. And having talked to the authors of this study, they were really convinced that this was a very effective intervention. This is a study of efficiency. This was an R01 that we did working with the Michigan Bariatric Surgery Collaborative, where we had 26 bariatric surgeons who participated, and they were compared with 25 bariatric surgeons in the collaborative who did not participate. We had 14 coaches, and people participated in between 1 and 9 coaching sessions. And as you can see here, we did not reach statistically significant difference, but the surgical complication rates, the relative risk post to pre for participants in the study was 0.81, although our confidence interval did cross 1. But we did show a statistically significant difference in our risk-adjusted operative times with a 14-minute decrease in sleeve gastrectomy times, which is a really big difference for that procedure. Finally, non-technical skills. This was a study out of Colorado where 20 surgeons worked with a retired peer surgeon, and they showed an increased quality of transition processes. So that means timeouts and handoffs. And this related positively to action and interpersonal processes. So things like coordination, communication, shared understanding of what they were doing. And this led then to quantitatively decreased delays and distractions in the OR. So again, even though we didn't see a change in the structured measurement within the Harvard study, we did see a difference here within the qualitative aspects of interpersonal skills. Now, I've talked a lot about the concept of coaching as helping with self-assessment and self-improvement. This was a study, the original study was done in trainees. This was a study that came out of Australia where they repeated the study in practicing surgeons. And they looked at what happened when somebody assessed themselves using that 5-point OSAT scale and a panel of experts assessed them. And before they underwent coaching, there was no correlation between how a surgeon assessed their own technical skills and how their peers assessed them, with a correlation coefficient of 0.3. However, once they went through coaching, there was a strong correlation with a correlation coefficient of 0.8 between how somebody assessed their own performance and how they were assessed by others. Similarly, they were able to show that the difference between the OSAT's expert score of themselves decreased post compared to pre-coaching. And then finally, this concept of the acquisition of new skills. So this was a study we did where we partnered with Johnson & Johnson, and we took surgeons who had gone through some of their weekend courses to try to adopt new technologies or new procedures and weren't really getting them into their practice the way they wanted to. And so the idea was to pair people who had gone through that didactic, that simulation, that cadaver training, whatever the training was, and then pair them with a surgical coach who could help them review videos, help support them as they're trying to actually then transition that into their practice and adopt that into their practice. And so this was 23 gynecologists, thoracic surgeons, and orthopedic surgeons who worked with 13 peer coaches. And as you can see here, we saw an increase in their procedural confidence, their technology confidence, and their goal progression by participating with a coach. So how do we move this into the real world, into practice? So I would argue that now's the time. We're kind of at a pivotal moment, I think, in surgery. With all of this data coming out, we as surgeons are starting to feel even more professional responsibility for our patients and for optimizing our technical skill, given this emerging data on the relationship between our own personal skill and how our patients do. The ABMS boards are looking for programs that can help to meet these new requirements that the ABMS is putting out related to continuous certification and changing that to really focus on the summative evaluation. And the COVID pandemic has really accelerated the adoption of virtual and distance learning activities, which creates new opportunities for us to interact in different ways. So as we think about moving from outcomes measurement to performance improvement, I think one of the most important tools we're going to have is video. Video is going to allow us to not only have you have those quality metrics around your mortality rate, your admission rate, whatever your length of stay, whatever those outcomes are, but also have these video-based assessments. And I'm going to talk a little bit about what's happening in video-based assessments in a second. But then to move into, again, identifying areas and setting goals for improvement, reflecting on practice, and making intentional adjustments with accountability. So video-based assessments offer us the ability to measure performance beyond patient outcomes, but really have to be paired with some kind of a performance improvement. And again, I would argue, and I hope we can spend some time talking about this in the discussion period, that this is a key opportunity for professional surgical societies to develop procedure-specific VBAs and to provide infrastructure for coaching programs. So these are the types of traditional tools that we've had. We've had these validated instruments for a while. I've talked about the OSATs one, which measures technical skill. NOTS is one that measures non-technical skill. There's other ones out there. There's goals, gears. People have probably heard of a lot of these. But a number of our different specialty societies are starting to move into coming up with assessment tools that are more procedure specific. And using these particularly for people as they're finishing fellowships. So this is an example from ASCARS from 2017, where they developed a colectomy specific tool, which was based on 8 categories plus an overall assessment and was able to differentiate surgeons based on their skill level. Similarly, there is a ton of work going on within SAGES. This was around video, around lap fundoplication, which was the first procedure that they did. But the idea is they identified 5 key procedural steps with 11 sub-steps, 9 required skills, and then 42 common errors. Now, again, you can't do this that frequently. This is an incredibly labor-intensive thing to do. But if you think about iteratively doing this for folks, it can really help to give them feedback on how they're doing related to a specific key procedure. There's also a lot of work going on in artificial intelligence. This was a study from the American Surgical, I believe, either last year or the year before, from the group at Stanford, which was looking at coming up with ways that we can do automated analysis of procedures to break it down into key steps, and then to look for whether or not, for example, you identify the critical view of safety when doing a lap chole. The American Board of Surgery, again, in response to that ABMS call for changing the way that we're doing continuing certification, has put together a VBA task force and just completed a pilot working with a number of different companies to see if surgeons can use video-based assessments as part of their approach to continuing certification. These were the 4 companies that they worked with, and these are just an example of the number of companies out there that are developing the capacity to support this work around video sharing between surgeons. So the question then is, once you have these videos, how do you move into this other area? And I want to talk a little bit about some of the work that we've been doing with the Academy. And I'm going to start actually by sharing my own experience. So when I was in Wisconsin, we developed a quality collaborative across the state where we got all the surgeons in the state to participate in sharing data. One of our first studies was looking at re-excision after breast conserving surgery, because that was something that was done really in a lot of different settings. So what you see here is my report. So we all like to think that we're better than average. Half of us are not. I was in the half that was not. This was a little bit of a blow to my ego, right? Here I was at the University of Wisconsin, and I was on the higher side in terms of my re-excision rate. Went through all sorts of explanations for why that was. I get the more complicated things. I'm pushing the envelope, yada, yada, yada. At the end of the day, I had room for improvement. So my 60-day re-excision rate was 23% in 2018. So I took a step back and I said, well, what's a realistic thing that I would like to do? And I wanted to drop myself to be average. So I wanted to go from 23% to 14%. How was I going to do that? I knew what to do. I knew that I needed to be taking shave margins. I knew that there were different things I could be doing, but I was unable to make those changes myself. And so I partnered with a coach, and he was a general surgeon who had a lot of breasts that he did in his practice. And we sat down and we talked about our practices, and I showed him this beautiful specimen that I had with, my cancer right in the middle. He said, "That is really small." I said, "What are you talking about?" I was like, "This looks good to me. It's right in the middle." And so we actually went and looked at the size of his specimens and the size of my specimens, and they were significantly bigger than mine. And I was like, "Well, you're just taking too much tissue. I have beautiful cosmetic outcomes." So we actually went to the literature, and lo and behold, the average size of specimens was closer to his than to mine. And so that led me to believe that I could take more tissue. And rather than changing the size of what I did, I just really tried to hold myself accountable to taking shave margins in all of the 6 directions after I take out my final specimen. And he and I worked together to come up with strategies to do that, right? Because when you're in the operating room, you're looking, you're like, but it's a beautiful specimen. It's really easy to say no and not do it. So I would label all 6 of my specimen jars before I scrubbed. I would tell the scrub tech and the resident, "Don't let me talk myself out of doing this. Hold me accountable, make me do this." And so I just want to point out one other thing. So there was a randomized controlled trial in the New England Journal, which decreased the re-excision rate by 67% by taking these shave margins. So there's good level 1 evidence to do it. And the American Society of Breast Surgeons actually put together a group to look at what was the best practices to do that. And I just want to point out that I'm an author on that best practices toolbox, but I still wasn't making those changes in my own practice until I worked with a coach to hold me accountable. So this was my baseline rate in 2018, and this was my report in 2019. I dropped my rate from 23% to 14%. So that meant 9% less of my patients were getting a re-excision because I was willing to look at my practice and work with another coach to figure out how I could get better. So I know a lot of people out there are thinking, well, I'm at the top of my game, right? I don't need to do that. Again, I'm one of those high performers. So I want to use an example from the NBA to suggest why, even if you're the best on that chart, you can still get better. So this is a chart, a graph where along the x-axis are the games during a season, and along the y-axis are the number of three-point shots made. And as you can see, if you look at 2015, 2013, 2014, all of those, Steph Curry, right? So 2013, 2014, 2015. Steph Curry has 3 out of the 5 best seasons. What happened in 2016? He reset what was possible. And how did he do that? He changed how he trained. He changed how he practiced. He changed what he did. He expanded the domains of performance by taking innovative approaches to his training. He'd wear goggles that distorted his vision. He'd have people throwing balls at him while he was trying to shoot. He actually redefined how far back he could take shots from so that people had to move out to change the defense, which actually even opened up the floor so that he could get more passes inside. He changed the game. And I would argue that if we think differently about the way that we train throughout practice, we can reset what's possible for our patients as well, no matter how good we are. So this is what it looks like. You pair up with a coach, you meet each other, you develop a rapport, you decide what goals you're going to work on. And then longitudinally, you have these coaching sessions where you look at different components of your practice and try to identify what you want to work on. As you make progress towards your goals, you can reset your goals and work on different goals. We have set this up so that you can get CME credit. If anyone's interested in doing this, SAGES has a program that's open right now. You can sign up, and SAGES is actually paying for you to participate with a coach, targeting people who are early in their practice. We also have an ongoing study. Again, you can partner with a coach for free through the ACHQC if you're a hernia surgeon. And then if neither of these apply to you, you can contact us at the Academy for Surgical Coaching and we can help you to get plugged in with a coach. So in summary, surgical coaching offers an individualized approach to performance improvement and continuing education that is based on adult learning principles. Surgical coaching addresses a major gap in medical education by providing feedback and a major gap in quality by providing action plans and accountability to help surgeons change the way they practice. There's a developing evidence base and increasing technical capacity to support surgical coaching. And I think coaching holds great promise to meet surgeons' needs for continuing professional development, as well as as an adjunct to traditional training paradigms. So my last point and why I'm so passionate about this and why I think it's really important. Video is going to be in the operating room, right? Let's look at what's happening in other aspects of our society. What's happening with police officers, right? This is going to happen. And if we don't drive the implementation and the development of these programs, it's going to be enforced upon us. Now, when I was in Boston, there was a case in Rhode Island where they had more than expected wrong side surgeries. And so the DPH came in and told them that they had to start video auditing timeouts and they didn't have to tell their staff that they were doing it. In Wisconsin, there's twice been a law that has been introduced, a bill to mandate that we provide videos to our patients if they request it. And so we've been trying to, at least when I was in Wisconsin, we were trying to actually submit an alternative that allowed us, at least as we were starting out, to have that be protected so that we could use it as a way to improve performance. But regardless, I think we have a really narrow window to do this right, to set it up so it's constructive and not punitive, so that it's based on formative evaluations. And if there are summative evaluations and we do get a score or a grade, it's used for a baseline evaluation and identifying gaps and setting goals and the ability to track improvement. And finally, we really have to continue to generate new evidence to figure out if this works, and if it does, what's the best way to implement it. So with that, I'd like to open it up to discussion. I really look forward to people's thoughts. Thank you.
Thank you, Dr. Greenberg. That was fantastic. We will open it up for questions, discussion. If anybody has anything burning, there's a mic up here up front. Just introduce yourself and where you're from.
Hey, I'm John Sweeney. So in my former past, it's a long time ago too, but as a former athlete, we filmed everything and practice and games. And we had a saying that the eye in the sky does not lie. Because it was really clear if you were assignment correct or you were not. You did mention a little bit about the medical legal aspects and peer review, because I think this is really a great, fantastic idea, a direction we should go. So the first question is maybe elaborate on that a little bit, if you could. How can we do this in a way that we're protected as much as possible? And then the other question is, the hard question is if back in the day, if I wasn't assignment correct, I didn't play. And, so let's say that we put programs like these in place and we identify surgeons that aren't assignment correct and with coaching can't get up to the bar. What do we do about that? Fantastic talk. I really, really appreciate it.
Yeah, so those are great questions. So I've talked about the medical legal aspects of this now in 4 states. So Massachusetts, Wisconsin, Georgia, and now starting to have those conversations in North Carolina. The overarching perception of lawyers in this space is that it's more likely to show that you delivered standard of care than that you didn't. And if there was an egregious error, they'd actually rather know about it so they can settle rather than drag everybody through some kind of a long drawn out case. There are a number of different things that you can do to try to mitigate the chances that this would be discoverable. So the first is to have a very well-defined and pretty conservative retention policy around videos. So in general, 30 days. Nobody does anything within 30 days. And if you destroy your video at 30 days as part of policy, it's not destruction of evidence. The There's also, when we have coaches work with participants through the academy, we have them basically sign an agreement saying that they're practicing within their scope of practice and that this is peer review to try to improve and that they're not held liable for any of the advice that they're given as part of the coaching procedures. Now, again, at the end of the day, nobody's tested any of this in a court of law, and there's been some really interesting panels. I would encourage you all to look at Alex, I'm blanking on his last name, Langerman, I believe, from Vanderbilt. Is that right? Is that his last name? Thank you. He is an ENT surgeon who put together a fantastic symposium where he brought together a bunch of experts around this to talk about what the different issues are. So it's far from straightforward, but I do think that people are thinking about it. And again, these things are happening. And if, you know, again, we can continue to bury our heads in the sand about it, but I would argue that we need to sort of take these things on. In terms of the second, that's what I want to avoid us getting to, basically, is us going from no oversight to all of a sudden we're going to have some kind of a summative evaluation based on your video about whether or not you can practice. And I worry that if we sort of take that huge jump, that's really going to be a disservice to our profession.
Sunil Givergis, Vanderbilt, thanks again for that wonderful talk. I really appreciate your insights into how we can change our frame of mind regarding surgical coaching. I'm PGY 29, learning every day. I mean that sincerely, not only because I play the role of vice chair for surgical education at Vanderbilt, but also because I have the pleasure of operating with my partners in many cases, and I get feedback from peer directly. But one thing that I have found challenging with the idea of coaching is that in academics, it's often used in a punitive way. Somebody acts out, somebody has a really bad outcome, and they get routed to a coach. And speaking with Ken Sharp a moment ago, he introduced an idea to me that we should probably include this in recruitment packages for chairs, for junior faculty, to say, hey, listen, in order to help you transition to practice, we would like to offer you this. Is there a move toward that, or does it essentially still live in a punitive world, surgical coaching?
Yeah, I think everybody should have a coach as they're transitioning to practice. It's a safe space. It's not your, your colleagues and your partners who you're trying to establish your rapport with, a place where you can go and talk about some of the issues that you're having as you're trying to develop that independence. We all know that's like the hardest year of your career. We did talk in the past about trying to have something within the Southeast, within the educational consortium down here, to see if there was a way for us to offer that within sort of our region for people who were going into practice. I would love to see people have those kinds of programs. That's what SAGES is doing. That program started out really targeting the fellows from last year. We're expanding it a little bit to other folks in practice. But I think it's a great place to start.
I think the idea of having that part of the recruitment package is really interesting. I would just even go so far and say, don't make it optional, make it mandatory, because I think, first of all, there's even some data and literature that those that reject those offers are the ones who most need it. I also think it just needs to become normal. And the moment you let people pick and choose, you again give it this touch of maybe something is wrong with you, you're not confident in your skill, but make it normal. Everybody does it. Then it does not become something that is in that area of deficiency.
Colin Martin, UAB, thank you for your talk. Really appreciate it. The question is a little bit tangential to medical legal, is who has access to the data, particularly the patients in the community. And I can imagine that if we're looking for a surgeon for a family member, we want the surgeon with the best outcomes. Or if a surgeon is on the low end of the spectrum with the best outcomes, that might be a tool for recruitment in the community for business to grow his or her practice. So can you just talk about, should this data be made public to the community for selecting surgeons?
Yeah, I think that's another question that needs to be answered. I think there's a lot of people who think that these should be made available to patients. I think there are surgeons that show videos to their patients already. I think individual organizations really need to figure out how they're going to manage video and who they're going to allow access to.
Thanks.
Now, I have a question about the athlete aspect, and I like the idea of comparing us to high performance athletes. I think it's much more apt than flying airplanes. But the other issue is, I feel, the missing link when you look at how athletes function, the ratio between training and competition. And we're essentially competing 99% of the time because only that makes money. And 1% is training. We also don't sleep enough and we don't eat well. And I think those are all important aspects when you look at how do high functioning athletes become top performers. It is by doing almost everything the other way around than we as surgeons do, with inadequate sleep and mostly performing, rarely training. How do we bring that in when we talk about us as high performance athletes?
Yeah, so I don't think we're ever going to obviously be having anywhere near the ratio of practice to performance. We're always going to be mostly performance. And so I think that this really needs to be something that's done at intervals throughout your career, whether it's, every 2 years, every 3 years, at some interval point, you go through a coaching program to sort of see where you are, assess your gap, figure out what you're going to work on for the next couple of years. And again, I see it as using some of the skill, some of the techniques that they use in athletics, but again, it's not going to be the same paradigm in my mind. I don't know if you have other thoughts.
I think to some degree, in terms of other thoughts, and then we'll have a next question. I think to some degree, we need to emphasize again that this part of training is a valuable part of what we do. And I think it also goes in when I look at the academic setting. I'm early mid-career faculty at this point, and I had senior partners who would help me in the beginning in my practice and try to essentially coach me, but it always came at the cost of them producing RVUs, which is how we're being measured. And I think some of that, I wonder if some of that could come from within. Ideally, the idea of joining, especially an academic division, is that you're there as junior faculty and you have more senior people that can improve your skill and help you. But that has really just been devalued because the time I spent teaching or coaching a more junior faculty member is time that I am not doing anything that shows up either on my CV or in my RVU spreadsheet. And I do think there is administration is needed to realize that, let's say, 20% of your practice should be measured in you teaching other people as opposed to producing more RVUs.
Well, and I would argue that what you said is only magnified for people that are in private practice or rural practice, where it's even more focused on RVUs. There's even fewer people. Many people are practicing on their own and don't even have those partners to have those relationships with.
William Hope, Wilmington, North Carolina. Thanks, that's great. I think along those lines, it's obviously for people that review videos, and I know y'all have done a lot of work on this, it's a very labor intensive process. So I think the AI, which I don't totally understand AI, but I think that idea is really fascinating. And I know they did some work with breast radiography and showed that they can like read mammograms pretty well. So I think that may be the answer. I don't know if y'all have any updates on or experience. If you can really break down a surgery that AI could fix, that may be a solution to some of those problems.
Yeah, I think we're starting to see an acceleration in the amount of work that's being done in this space, and that industry is starting to get involved. So it's not just academics, which means the pace will be very different. That being said, I do think that video can be useful just as an adjunct, where you can fast forward, you can rewind, like you can hit points, you can go through a 4-hour case in 20 to 30 minutes. But as we get better and better at figuring this out, it's going to be much more efficient and much more standardized, which is something that we desperately need. The key in my mind, though, is we just need more videos, right? The more videos we have, the more we can develop those computer algorithms, the more we can analyze them and figure out how we measure those different things.
Great talk, Caprice. I think it was, the thing about surgery is that a surgeon really, if he or she is honest with him or herself, really knows where the gaps are. And the result is avoiding those surgeries or those operations where you're going to get in trouble. And that in essence, you kind of self-select out. The real danger is when a surgeon is not honest with him or herself and denies that he or she does not have that skill and cannot do that operation. So there's the rub. And that's the reason why it has to be almost uniformly applied.
Yeah, and I think that's why the self-assessment component is so important, getting people that ability to really have a realistic understanding of where they are.
Chris, that was great. I'm going to follow up on John Sweeney's question a little bit, because I practice at a state that basically every email, every text is accessible to public record. Even our quality assessments inside the hospital are often able to be gotten from the Gainesville Sun. So my question is, with the videos, 20 years ago when the BQI started inside the SVS, we had this PSO, which was basically allowed sort of de-identified data to be placed in a completely independent. Is there anything like that for video where, you know, nationally we could have a sort of patient safety organization whereby things would be sort of taken off out of state of Florida, moved to a repository in North Carolina, assessed, and then given people feedback? Because
Yeah.
it seems like to me the medical legal piece is I mean, everybody wants to get better. I don't think there's one person in this room that wouldn't want to get better. The issue is always medical legally. And if you could, can you comment on the sort of the PSO concept?
Yeah. I'll just say there's a lot of conversation in that space about PSOs and PSO status. I actually don't know offhand. I know Black Box and some of the other companies have been talking about how they can sort of carve out and have a space that is a PSO to be able to protect some of this. But I don't know if anyone has actually gotten approval yet.
This is Wasfi from Michigan. I got two questions. At what stage of person career would you think this will be coaching, and who determined that? The person himself, the surgeon, or the institution? And the second question is that would you agree that there's people uncoachable and should not be a surgeon? They do that in the football.
Yeah, so I personally think coaching is applicable at every stage of your career. I think we're going to have more traction as people who are in leadership roles and senior people are coached themselves and talk about it and talk about the experience and talk about what they learned. When we did the Brigham study, the first people to participate were the chair of surgery, the chief of general surgery, and the program director. So having leaders who lead the way as opposed to just having it be people going, starting out in practice, I think is a nice way to do it. Again, I think we're going to have early adopters and people that want to do it and that want to do these innovative things and that don't let the medical legal things worry them. And that's the way that any change happens, right? You have your early adopters who have experience, people get more comfortable, we figure out the kinks, and then we make it more and more just the norm that people do it. Are there people that are uncoachable? Yes, of course. And again, I think that is something that we're going to have to work through. One of the reasons I really, again, think we need to start with formative evaluations and encouraging people to participate as opposed to what we actually see is because I don't think we have the data yet to know what is good performance. What does it mean to be a safe surgeon? We don't have those metrics yet, and we need to figure those metrics out. And I think those are the types of research projects that we'll be able to do if we start having more of these programs.
I think what you said there was a key point. When you have leaders that show their own coaching, that's a good example. You put your own data right up there. I'm a chair at UNC. Here's my data. It wasn't great. I did this to improve it. I think that's a huge step that, you know, seeing people in leadership roles use coaching is fantastic. I had a question about some people have kind of touched on this is it's easy to see who definitely needs coaching, right? When you come out of practice or transitioning back into practice or poor quality. But do you really think that everybody will need coaching? Like Ken Sharp, does he need coaching? And then how do you, he's nodding yes, but I would say probably not surgical coaching. But if it's going to be every 3-5 years, one, who runs that? Is that the American Board of Surgery? Is that the college? Is it anybody and you can choose which one you're on? And then where do we get all the coaches? If everybody has to do it, how do we find that many coaches?
Yeah, I think those are all really great questions and some of the logistical challenges that we have to work through. So again, I would argue that everybody needs coaching. I think practice changes quickly enough that no matter how good you are, every couple of years, it's worth looking at sort of where are the gaps, where are the things that you want to get better at. You know, we do that now, right? We take that open book test for the board every couple of years, and the goal is really just to kind of make sure that you're up to date, you know what's happening. In terms of who has ownership of this, my own personal view is that this should be, again, an option for meeting your continuing certification requirements for the board. And that the societies really should have ownership of this, that we should have programs through our societies, especially our state and regional societies. Many of our state and regional societies started out because people wanted to get together to try to figure out how to improve quality. And I think getting back to those roots by starting to figure out how we have these programs is really important. Again, there are different ways that we can train up coaches. There are different coaches we can find, through the academy. We do a 6-hour training program. We have over 200 trained coaches at this point. I would say gynecology has actually taken to this much better than we have in surgery and have had a lot more traction. And I think some of that is because they have so many people that move between sort of doing more OB and doing more minimally invasive surgery, that people are looking for getting their skills back as they're moving back into sort of the benign GYN space. That's where they've had a lot of traction.
I think from the medical legal aspect, the most pragmatic solution seems to be to time out those videos. And I wonder if it even makes sense, not even 30 days, but 14 days in a way you need to be able to time it. But you learn the most if you want to review your case, what you did, it should be pretty close to you doing it. So I wonder if that is the way forward. You simply review the video within 14 days. It goes a little bit to the timing aspect I talked about, that being valued, but that way the video simply is gone and nobody can use it. Because I would put myself on the side, I'd be skeptical showing patients the video, because I just simply think the patients, you can show them what you want them to see, and it will be used as marketing. I think it was a good point. I think the moment we open that up, there'll be billboards coming up. Our surgeons are in the top decile in the state, and it will be used for those purposes. So I think that should be kept within quality review and peer review.
Yeah, I mean, maybe, again, if we think about many of the state collaboratives, right, they signed a contract saying that they're not going to use the data from sharing in those quality collaboratives for marketing purposes. And somebody said they were from Michigan, but I know in Michigan, they've really held to that, and I think been really successful at preventing that data from being used for marketing purposes. In terms of retention, again, I think this is something you have to talk about with your risk and with your legal experts at your own institution, and figure out what people are comfortable with. There are institutions that are saving video indefinitely. There are people that are integrating it into the medical record. It just depends on how people think about risk, and each institution has different risk tolerance, right? Each of us has our own sort of personality in our own institutions and our own comfort level with these things.
Do we have any other audience questions?
Yeah.
All right, I think nobody is sad for leaving a few minutes early, especially now that the sun is finally coming out. So thank you again, everybody, for coming to our luncheon. Thank you, Dr. Greenberg, for giving us this fantastic talk today. Good video.